Dear Chairman, dear colleagues, first of all, I would like to thank Professor Amiran Revishvili for inviting me to this very prestigious meeting. I'm really honored to be in Moscow. Regarding concomitant tricuspid valve surgery, these are the subtitles that I would like to address. Something like why, when, how to intervene, and right atrium exclusion, and catheterization, cannulation things, and some about results. Let's start with why perform concomitant tricuspid valve surgery. Although it has been known as forgotten valve for years because of these two papers. One of them is coming from the godfather of the cardiology, Dr. Braunwald, in Circulation, saying that successful correction of left-sided valve lesions will cure moderate functional TR totally. And the second one is coming from the godfather of cardiac surgery, Carlos Brown, and saying that when pulmonary artery pressure is expected to drop after successful left-sided valve treatment, moderate TR will resolve. But it didn't happen like that. We know that almost 75% of secondary causes are related to left heart disease, left ventricular dysfunction, or valve disease resulting in pulmonary hypertension. Indeed, if you look at here, most of the mitral regurgitation can occur due to rheumatic disease, ischemic or degenerative mitral valve disease. And left-sided heart valve disease can enlarge left atrial size, left atrial pressure, and even may cause atrial fibrillation. And at the end, pulmonary hypertension can occur. And at the end, if you look at the mechanism here, right-sided hemodynamic, functional, and structural changes occurs, and then we have this sort of vicious cycle, like tricuspid annulus dilatation, right ventricular dilatation and dysfunction, as well as tricuspid regurgitation. If we deep dive to the effects of secondary TR during and following mitral valve surgery, leads to poorer functional status and leads to higher incidence of congenital heart failure and portends worse survival. Again, concomitant tricuspid valve surgery does not increase perioperative mortality, and on the other hand, if you leave it behind, reoperation for isolated TR carries high mortality. However, tricuspid regurgitation following successful mitral valve surgery occurs frequently at long-term follow-up, can be progressive or develop over time, is independent of tricuspid regurgitation severity and initial surgery, and also it is independent of pulmonary artery pressure decrease. So when to perform concomitant tricuspid valve surgery, we need to go, for this, we need to look at the guidelines. There are two guidelines. One of them is 2021 ECG-EX guidelines, and the second one is 2020 ACC-AHA guideline. And when we look at that, secondary TR are two types. One of them is with left-sided valve surgery, and the second secondary one is after left-sided valve surgery. And concomitant tricuspid valve surgery in case of severe TR is class 1 indication with B recommendation level, or in mild or moderate TR with tricuspid annular dilatation over 40 millimeter mercury is about 2A with the recommendation level of B. What has changed compared with 2017 guidelines? It was C in the past and C recommendation level in the past, and also right heart failure was mentioned. Now it's not mentioned. It's only mild and moderate TR is mentioning in the guidelines. In ACC-AHA guidelines in 2020, it's almost the same. And if you look at so for severe secondary TR is class 1, and non-severe one is 2A. And compared to guidelines 2014, there is almost no change, and reference papers are also a little bit old. Let's look at the technical points in concomitant tricuspid valve surgery. For venous drainage, we use femoral vein and internal jugular vein cannulation, and percutaneously or with open technique. And two-stage femoral venous cannula is really a miracle. If we find it, we use it at our university hospital. And but if we cannot find, we can even use standard single-stage femoral venous cannula. Whatever we use, vacuum-assisted venous drainage during cardiopulmonary bypass is mandatory. Here are the routes that we are using for internal jugular vein cannulation and femoral vein cannulation. But recently I started to use iliac cannulation to put one size larger cannula, and especially for kids as well. I'm using iliac cannulation with the same length of incision. Here is the appearance of patient just before the operation. If we're ready for any operation, it can be even re-operation as well. For cardiac protection, I usually use glutathione or beating glutathione, a one-shot cardioplegia, but it can be achievable with standard administration of cardioplegia as well. The last one is not is something that I don't prefer, because I don't want any extra catheter in front of me during this procedure, especially in minimal invasive setting. If you look at the suture map, we all know about Koch trigon, and we try to avoid even the rings are created according to that, but coronary right coronary is here, and we must really take care about that. We mustn't have deep bites, but this part is not safe as well, because if you look at this Calafiore's paper, it can be easily, the PDA can be easily caught if we go too deep in anterior, posterior, posterolateral part of right coronary as well. Which valve do we do first? My personal preference is to go mitral valve first and then tricuspid, because I try to avoid left atrial retraction and not to do any harm to the tricuspid prosthesis. And also, if the management of mitral valve prolongs, then I may take off the clamp, aortic cross clamp, and do it in fibrillating heart in order to protect, in order to help the cardiac protection. Right is something for some, let's speak something about right atrium exclusion from the blood. Tourniquets and snare placements to both SVC and IVC are my choice, but internal prolonged purse string can be also applied, especially in reoperations. Endoscopic bulldog clamps can be also applied. Double or single stage cannula and vacuum assisting is also some the other options. And balloon endotracheal tubes that I'll show you later has been also tried so far. As you can see here, in minimal invasive setting, we turn around inferior vena cava here and also superior vena cava. I'll try to, yeah, superior vena cava as well. But note that you have to apply a good vacuum on CPP in order to have this empty right atrium, otherwise it wouldn't be possible. And here you can see the double stage venous cannula, which is really helpful. It's as I called it, it's a miracle. And you don't see any blood in front of you, and you don't need tourniquets as well. But when we work with standard venous cannula, still it's possible when you apply up to sometimes 60 millimeter mercury of vacuum. Normally we apply only 20 to 30, and if we put an band there, still it is manageable. And thanks to Dr. Zacharias from England, I took his slides, this slide from him, and he introduced ballooned endotracheal tubes like this, and first sort of Zendinger technique. It can be applied and vacuum, and we can exclude the bloodstream in right atrium. And in right atrium opening, I also try to be less oblique in right atriotomy. I'll show you in a minute. And sometimes we can use stay-stitcher as well. As you can see here, I keep the incision as most parallel to the interatrial sulcus, so that I can apply left atrial retractor at the same manner that we apply to left atrial. So we keep it there and we use like this, and it's easy to apply. And in exposure can be even facilitated when we have chest adhesions. Then we put some stay sutures under that circumstances when we go to redo surgery. I just wanted to say about the enlargement of augmentation of anterior leaflet. We only apply it over 8 millimeter of tethering, and if I have doubt, I replace it with a bioprosthesis. Why we use ring? It's a more standardized technique, and both anterior and posterior annulus tension this distribution it can be achieved, and is reproducible. And indeed, 3D rings are again biomedical vehicles to use it. Although there is such an information about if the diameter of chest X-ray at the chest X-ray less than 14.5 centimeter, the operation would be, minimally invasive operation would be difficult, but now I'm operating in kids as well, in minimally invasive setting. I don't think it's too much a problem, but I think pectus excavatus can sometimes be a problem. There we need to go open technique. Let's talk about a little bit results. This is a perfect, very strong paper, although it's from 2011, from Leiden. Dr. Weir, Brown, Delgado, Robert Dion, and Joanne Marks. So they asked for this research, they say that they asked, can tricuspid angioplasty prevent progression of TR and right ventricular dilatation? The question is this, and it replies that yes, tricuspid angioplasty prevents it. I'll just show you the result of it. Actually divided two cohorts up to 2002 and 2004 in this paper. If the regurgitation more than grade 3 in both group, they applied tricuspid valvoplasty, and in less than 3 regurgitation and less than 40 millimeter in up to 2004 they didn't apply it, and the other group also they didn't apply it, but in the middle they applied the tricuspid valvoplasty when there is less regurgitation but analysis over 40. So the results were better in the second group. They are the second group. There are more recent studies about concomitant tricuspid surgery. I'll not mention about the first three, but just a little bit about Dr. Chipes, who is renowned woman scientist, cardiac surgeon. Chipes' result. This paper, it was about 645 patients with degenerative mitral valve disease, and they investigated impact of concomitant tricuspid angioplasty on tricuspid regurgitation, right ventricular function, and pulmonary arterial hypertension after repair of mitral valve prolapse. Here you can see that at the first part, you can see that after 5 years of follow-up, it has been shown that less TR occurred in more than 400 cases with concomitant patients. But if you look at the other 200 patients, it happened a little bit more. So after 4 years, after 5 years, pulmonary artery pressure recovery has been shown in 400 cases with tricuspid repair, and also at the last figure 4, you can see that right ventricular function recovery has occurred if tricuspid plasty has been added to mitral valve repair. Just one more point from this paper is very interesting. Dr. Chipre is recommending tricuspid valve repair when it is over, when regurgitation is over 3 or 4 plus, and also over 40 millimeter, but if there is a significant size mismatch between leaflet and annulus on direct inspection, she says that leave alone if there is a mismatch in your direct vision. So last but not least, I would like to mention when not to perform concomitant tricuspid valve surgery. It is a triad of functional TR, right ventricular failure, and pulmonary hypertension, as you can see here. And the definitions of these are like, if we talk about right ventricular failure, arrhythmias, reduced cardiac output, and fluid retention. If there is such a thing, we must try to avoid it. And but sometimes we don't. We see the balance in the conditions. Not always. We don't apply tricuspid annuloplasty to any arrhythmia or fluid retention case. And also, right ventricular dysfunction is important, and it's defined as abnormal right ventricular filling or contraction, including TAPSE, and right ventricular EF. And pulmonary hypertension is very important issue. It's if we have a very high pulmonary hypertension, it can be a contraindication. On the other hand, pulmonary if there is a low pulmonary artery pressure, it can be also very low pulmonary artery pressure. It can also be dangerous. In conclusion, prevention of late TR after mitral valve surgery is an important goal. Goals of tricuspid valve repair surgery are similar to those in mitral valve surgery, and concomitant tricuspid valve repair in case of tricuspid valve annulus dilatation leads to less TR and better right ventricular function, according to many papers, and caution in patients with late TR and pulmonary artery pressure drop, which means high pulmonary vascular resistance and pulmonary and right ventricular dysfunction. We have to be very careful in this group, and I think these are the, thank you very much.